Yeah, good morning from our side. I've been introduced already. I am Silke Andrich. I'm leading this session, Metabolic Disease, together with Professor Alexandra Nieters. We have 3 excellent speakers today. Talks are scheduled for 12 minutes, and we have time for questions or discussions. And the first speaker is Professor Alexandra Nieters from Freiburg. She will present findings regarding persistent symptoms 2 years after COVID infection. Please welcome Professor Nieters.
Yeah, thanks, Silke, for the nice introduction. Yeah, I'm standing here on behalf of the EPILOC working group. EPILOC stands for Epidemiology of Long COVID. And our working group consists of clinicians and scientists from the 4 university clinics and universities in the state of Baden-Württemberg, Tübingen, Ulm, Freiburg, Heidelberg, and what did I forget? Heidelberg. Yeah. So we are also working together with the Center for Mental Health in Mannheim. And I'm representing here our work, which was in parts recently published in PLOS Medicine. I have no conflicts of interest, and here is the study design of the EPILOC study. You see also the representing universities on top. And we have initiated our study already in 2020 when we collaborated with the health departments and invited individuals with PCR-confirmed SARS-CoV-2 infection to participate in a survey, in a questionnaire survey. We sent out more than 50,000 questionnaires in the state of Baden-Württemberg, and we received back 11,700. From these questionnaires, we defined our putative long COVID individuals with the following definition. So the people should have had at least one persisting symptom of grade moderate to severe, and they would not have regained full health and full working capacity. And with that definition, we went into the second phase of our study, where we wanted to better clinically look at our individuals which had putative long COVID and controls. So we selected 982 cases from this initial phase and 576 controls with a median of 17.2 months post-infection. We then, in the different university clinics, engaged in comprehensive medical examination, performed cognitive tests. We had a whole battery of standardized questionnaires. We have had biomarker measurements performed, and we completed biobanking. We also have a third phase of that study, which is not content of today's talk. Here are, first of all, the main people involved in this paper, which we just published. And you see here that from phase 1 to phase 2, we had 2/3 of the patients that remained cases. So the majority of cases still remain cases after almost 2 years after the acute infection. We had a few people that improved to the intermediate state or even recovered. And we also had a few people that were initially long COVID-free that developed long COVID, and the predictors were lower educational status and a secondary SARS-CoV-2 infection, whether the predictors of significant improvement were higher education, no medical treatment of acute infection, and some other indicators of a less severe acute infection status. And now I would like to draw your attention to the next slide, where we basically compare the different main symptom categories between phase 1 and phase 2. You see here that also in our study, fatigue, neurocognitive impairments, chest symptoms, smell and taste impairments, and anxiety, depression, or sleep disorders were our main symptoms category. This basically remained very similar in phase 2. However, we see differences. So we see specifically for smell and taste disorder, that's in phase 2, less people were affected. but we do not see much of an improvement with neurocognitive impairment and also anxiety, depression, and sleep disorders. When we excluded from this 1,500 individuals all those that had previous health conditions, and when we excluded people that had another explanation for the persisting symptoms, we basically see very similar findings of our symptom prevalences. So fatigue, neurocognitive impairments being the top symptoms here. And then we looked at quite a number of different standardized questionnaires, and what was very interesting that in the self-assessed questionnaires, we found a very extreme differentiation between the people that had the worst performance, so the persistent cases, and the stable controls, and the people that improved as cases, and the stable controls that deteriorated were in between. And what was very interesting, that the area under the curve was above 0.9, so we could discriminate these two groups very efficiently by these instruments, which addressed subjective cognitive disturbances, sleep impairment, fatigue, quality of life, and so on. On the other hand, when we applied tests for neurocognitive capabilities, like the MOCA test or the TMTB trail making test, then we could also see significant differences between the persisting cases and the controls. However, the area under the curve was much less pronounced and was only a little higher than the area under the curve after adjustment for age, sex, study center, and university entrance qualification. So we see this very big differences between the self-assessed and these more maybe objective measures. However, we then had other findings which were significant. Out of time reasons, I skipped them because you can all read them in our publication, which was recently published. But complement activity we could not find in our big study, actually. I can maybe conclude here. And I would now like to take the time to also address the specific subgroup we have investigated, the people with post-exertional malaise. So we had more than 1/3 of the individuals of the persisting cases presenting this exercise intolerance, and we had almost 12% with symptoms compatible with ME/CFS. And we could also find that all the different symptoms, as you see here in this pyramid, were more pronounced among the people with PEM than among the cases without PEM. So you see the dark brownish and the grayish colors were more frequent among these individuals. They had more pain, they had more concentration difficulties, memory disturbances, and obviously also fatigue. And all the different dimensions we looked at with the MOCA test and also grip strength and so on were more severe in these PEM individuals. So this is a very severely affected subgroup of long COVID in our population. Now I would like, because this is a metabolomic session, to give you some first peek into our metabolomic data. I'm very happy that Max von der Linde is here in the group, from the group of Melanie Burrius, who did the analysis, and Professor Uta Merle is the PI of the project, and the measurements were performed in Heidelberg in the lab of Dr. Poschet. And I do not want to go over all the technical parts out of time reason, but I present you now the study population. So we investigated 1,000 individuals, more females than males, more cases than controls. And what you can also see that we had significant differences in the study populations. So we needed to adjust for certain variables to have valid data, because the BMI distribution, the body fat percentage, was much higher among our cases. So here you see what happens to our significant results if we adjust for all these covariates. So not much happened with sex and age because it was a matched study design, but then when you adjust for percentage body fat, you see that there's a drop in significant values from 25 to 8. If you then continue adjustment for smoking and university qualification, only 2 candidates remain in our large study population. I can reveal you now one of our hits. quickly because it's all not published. And we have here the results on the left side, unadjusted or not adjusted for body fat percentage. But if you adjust, then only serotonin and another factor, which I will reveal later when we have published, remain significant in this large study population. And the result is, as you can see here, largely driven by women. We do not see that in the male population here in our data. And what is interesting, that there is quite some further evidence that serotonin depletion has a role in long COVID. This is from a Cell publication last year. They did mouse work, they did organoid work, and also had investigated patient cohorts, and they could also see a depletion of serotonin in the people, not only with acute COVID, but also among those that developed long COVID. And what was very interesting is also that there were several publications now that selective serotonin reuptake inhibitors were inversely associated with long COVID in several studies, like the US National COVID-19 Cohort Collaborative data, where they found a 29% reduction among the people that consumed these or were treated with these drugs. And this was also found basically in a population of people with depressive conditions, so that we believe that there is some real mechanism behind serotonin. And what they proposed is that the viral infection leads actually to a virally induced type 1 interferon induction, and that this leads to low serotonin level, that this drives hypercoagulation and platelet dysfunction, and is also involved in affecting the vagal nerve, which then has some role also in neurological dysfunction, leading eventually to long COVID. And I believe that it's basically not maybe only the virus that here has a role, but it's a strong genetic and epigenetic variability in the serotonin pathways. So we see differences between men and women. Serotonin synthesis rates are lower in women. We have also tryptophan metabolism, where the women are more prone to alterations. The gut microbiome plays here a very important role, and also taurine as one of the supplements that has helped some people with dysbiosis was shown to lead to increased serotonin levels. So we believe that it's interesting to continue with serotonin as a risk factor, and also in our EPILOC study population, we would like to combine this epidemiological metabolomic data with data on the microbiome. We have first data, so this is just a peek into our data, where we see in women with PAM reduced alpha diversity levels. We have whole genome sequencing data, which is now in the process to being analyzed on almost 700 whole genomes. And we have also nice collaboration with Mannheim, and they helped us to derive polygenic risk scores, and we have lots of traits addressed here, and all this data is now available, so we can do combined analysis. And we also want to reach out to the community. I think it's very important that we collaborate here on the national and even on the international level, that we systematically test the promising markers here, also regarding data pooling and meta-analysis. We should team up with all the large initiatives. Many people are here. I have definitely forgotten some of the initiatives which are important, but the NUM-NAPCON, all the initiatives of the DZDs are here to name. The Long Care, the new project which was mentioned this morning, as well as PetNet with the children and young people, and also prospective cohorts, where I have to name the NARCO study as one important source to really get pre-pandemic biosamples, and also patients' organizations, because they know a lot about their disease and they are think to be included. So now I would like to come to an end, showing you the metabolome, the microbiome of many of our patients, so very colorful, and on top of that, all the people that have contributed. I want to thank all the state of Baden-Württemberg for supporting us and all the different people. Raphael Peters here in the room. I see also Max von der Linde, and I think Claudia Schilling is coming later, and also Herr Kreuslich is here. So we have a lot of people from our study that can help me to answer your questions. Thank you very much.
Thank you, Alexandra, for this interesting presentation. We have one online question. How did you assess depression with PHQ-9?
Yes.
Okay. Online questions. Now I can see myself. It's a bit after the time on the screen. Yeah, we would like to encourage you to post online questions. At the moment there are none, so maybe in this room, are there any questions from the audience?
Okay.
Yes, you can use the microphone here, but I'll also come to your place.
Dankeschön. I suffered myself from post-COVID and long COVID, and I'm recently working for a program where we did a research on fatigue as well. And my question is how you measure the change in fatigue as a symptom. Maybe you explained it, but I didn't fully understand. So as far as I know, there's no biomarker for fatigue as symptom itself. So how did you measure the change?
One instrument which we used, and we also had, in our questionnaires, we had also a question addressed which were derived from the McPowell questionnaire, the Canadian questionnaire, which was adapted by, I think, Uta Behrens and so on for querying MECFS. So this was used here in our study as well. Yeah.
Just another comment. SSRIs, very commonly used in Germany is venlafaxine, which is actually very cardiotoxic. So this is perhaps just a little comment from a cardiovascular clinical pharmacologist that we also need to be very careful with choice of drugs. European Society of Cardiology has a very clear guidance on which are the preferred SSRIs when there is also cardiac disease involved. And the very top of the list comes sertraline. So I hope this is a helpful comment to...
Yeah, thank you very much for this very important comment. And I hope that you do not now see this data I have presented as now argument to take drugs. That's definitely not my interest, but I just wanted to understand the pathway a bit better to support this. So I think dietary supplementation could be here on the tryptophan pathway a much better approach, certainly, than to take these drugs. But I think to understand better our biomarker results, I wanted to mention this big study that have been conducted, but not to now stimulate you to take these drugs without need.
There are some more comments or questions online. I will start with the last one, and then I will hand it over to you, and you will have a look which question you have not already answered to serotonin. The last question is, how does this relate to MECFS?
Yeah, actually in MECFS, you mean the data on serotonin? There have been some, I think, clinical trials which were not successful. This is what I read, but I'm also not an expert in that field, so maybe there are other people that can more competently answer that question. But certainly what we want to do is also look at our subgroup of PEM. So far, I think, Max, you can later comment on that maybe in the coffee break, but the PEM data did not reflect so much the serotonin finding. Am I correct? Yeah. So that maybe is a subgroup, the PEM people, that where the serotonin was not the most important metabolite which we identified, but it's not published yet. That's why I didn't present it today.
Okay, so maybe you have a look, and we have time for one last question online.
There was another one, how about treating post-COVID with SSRI, so I mentioned that already. Is that related to serotonin or the serotonin autoantibodies that were found at the University Hospital Tübingen? Actually, I don't know if that is related to that. Maybe somebody is here from Tübingen can answer. And then I think, are there future plans? Yeah, the future plans are to bring all these data sets together, to reach out to the community, to get larger data set, to be able then to hopefully get more light into this mystery of long COVID ME/CFS.
Okay. So thank you very much again. Our next speaker is Professor Stefan Bornstein from Dresden. And he will discuss the link or interplay between diabetes and post-infectious syndromes.
Thank you for having me for this wonderful meeting here. I think it's exactly what we need, this interdisciplinary approach. So thanks for Stephanie and Werner for organizing this. I think it's a fantastic topic also for young scientists and young doctors to focus on, because it's really interdisciplinary. And I would like to go one step back and start a little bit provocative by saying, is there a co-evolution of diabetes and these post-infectious syndromes? I like to speak about post-infectious, not so much long COVID, because we have seen that and we see it also after other infection. It may also be a post-influenza syndrome. And how can we understand the dimension of this crosstalk, specifically now with metabolic disease and infections? And what is the role of metabolic and endocrine diseases in infection, post-infectious syndromes? And then, most importantly, we have these patients still coming to us. What can we offer our patients? Because in the end, that's what we have to address. So all of us know that this crosstalk with virus has been going on for millions of years, and not only to our disadvantages, you know. Some of our intelligence has been transferred to us by virus, by viral information, and there are many books and quite interesting philosophical aspects about this. And this, of course, relates also if bacteria and virus is driving our evolution. It's using, interestingly, a lot of endocrine pathways. So like the SARS-CoV-2 was using an endocrine receptor as an entry, like AC2. Hormones are key messengers, of course, in driving evolutions. And virus and bacteria, in fact, have learned to target these metabolic endocrine pathways. And this is not only related, again, to negative aspects. If you think about the interaction with pathogen receptors, it's training our immune system, as we all know. It's adapting to stress, hormonal metabolic hemostasis. There's an endocrine virome that we realize, not only microbiome, but it's also interesting that recent data have shown that certain forms of virus can produce insulin-like factors, and that's something that shows how important this metabolic or endocrine virology is. But of course, if this gets out of range, then endocrine cell death, metabolic organ failure, chronic inflammation, this metabolism, eventually also in severe forms, then contributing to sepsis. If you have adrenal failure, you go into shock. And these viral-like peptides, insulin-like form, can also produce some effects on hyper or hypoglycemia. But lo and behold, what we have to understand is that this interaction of metabolism and viral infection is also, they depend on each other. It's also a form of symbiosis. Viral infections, of course, contribute, as we will see, to metabolic disease, but also inducing insulin resistance and other factors. It seems that it induces our defense. Our defense, like for example, the interferon system. And then, of course, infections have learned to hide in our body, and infection may persist for a long time in human tissue. We've just shown that by looking into fat cells, adipose tissue, and the storage of SARS-CoV-2. But that's known for mycobacteria, for herpes, for many other viruses that have a long-term existence within our body. And why have virus and bacteria chosen to target these particular adipose or metabolic tissues? Of course, this reservoir of our fat tissue is a very nice place if you were a virus or bacteria to go into, because it's immunoprotected. They can't catch you there, so it's a good place to stay in. And why endocrine cells, like beta cells? Because they have a machinery, and this machinery is necessary for the virus. They're producing rapidly insulin proteins. They have a replicative machinery. See this amount of SER or RAR of rough endoplasmatic reticulum, so they can use these cells for their own propagation. And of course, diabetic patients that we treat every day, they have an enormous interaction, and it's an enormous dimension of diabetes and viral bacterial infections, but also parasites and fungals. And they contribute dramatically, and probably we are still underestimating this, to the cardiovascular, neurodegenerative complications of our patients. And also, we know that this group of diabetic patients is a challenge in many ways. It has a reduced compliance, so the most prominent, or the group of patients that is most vulnerable is the one that is less or least interested in getting their vaccinations. And they also had, during the pandemic, an enhanced rate of breakthrough infections. Why is this? Probably because metabolic disease is a mild form of immune deficiency, as we know. So we have started a large consortium. I'm very thankful to the German Research Foundation and an international research training grant with the ETH and with the University of Zurich, training young people, or closely PhDs, but also clinicians, in a broad way on these mechanisms of clinical relevance of bidirectional relationship with viral infections and metabolic disease. And what have we learned? We have learned from the lessons from the pandemic, especially in the beginning. It was striking when the first data, you remember, came out from Italy, northern Italy, that a large part of those patients, the severely affected, those patients that initially died, were patients with some forms of metabolic syndrome, diabetes, pre-diabetes, or they had hypertension, obesity. The first patients I remember that came in and that died rapidly was younger patients below the age of 50. Was a young lady that was really morbidly obese, and that was going on in a very rapid way, so like a cytokine shock. And that striking overlap, if you look into the maps, as you know, of those patients that died from COVID-19 and diabetes, and the distribution of obesity and diabetes is quite overlapping. And that, of course, may have also some relevance for the next pandemic or for the interaction on the basis of this evolutionary drive. But it's not limited to SARS-CoV-2, long COVID or COVID. It's also related to other diseases. We have increased risk in influenza and many bacterial infections, also in malaria or parasitic infections. So the pandemic has caused a significant increase, we have realized that over those years for various reasons, in metabolic disease. And that seems to be ongoing. It's a long-term effect that we have realized that's happening here. And we also learned that well-controlled blood glucose levels was kind of a prevention, was a protective for the outcome of these patients in the acute phase, but also in the chronic phase. And it is interesting to see that apparently this is also now translated to therapy. There are indeed more and more drugs, antiviral drugs, drugs that we use to treat, to target infections, that seem to have an effect, a good effect on metabolism some early data showing that even the progression from islet destruction and then type 1 diabetes, type 1 can be prevented by certain forms of antiviral drugs. On the other hand, even more importantly, many of our metabolic drugs that we use to treat high cholesterol or that we use to treat high blood sugar seem to be positive for preventing or keeping infections low, but also for preventing post-COVID. That may be related in statins to lowering lipids. We don't know why metformin was such an important factor in preventing or reducing long COVID occurrence. Viral infiltration of pancreatic islets has been shown, so there is something even in not highly severe diseases of COVID-19 and with symptoms, it was but milder infections, an infection of pancreatic islets, and this was apparently related to some increase over the years epidemiologically of diabetes type 1 incidence also in children. Yeah, and this is not only again related to the islets, to the insulin-producing cells, but also other endocrine metabolically relevant organs, like, for example, we looked into adrenals, adrenal regulation, and it was interesting to see that although the patients, some of them entered into a complete adrenal failure, mostly it was some milder form of infections that could be seen on these pathological slides. And it was also, if you do this in vitro, in cell lines, in primary cells, it's interesting that if you are under stress, if I stress you or you are stressed for external or internal stimuli, and the HPA axis is activated, you see that there is, in fact, an increased uptake, a susceptibility, vulnerability of viral, of SARS-CoV-2 uptake into these adrenal cells, which then leads to dysfunction of cortisol, of HPA axis, may then again contribute to metabolic and endocrine disease. And it's also interesting, we were looking into this, and I had quite a number of patients, that adrenal insufficiency, adrenal fatigue, some people talk about adrenal chronic fatigue, post-COVID syndromes, they're very overlapping. Not the same, definitely not the same, but if the patient, the way the patients are presenting is strikingly overlapping. And if we had about 2,000 COVID patients, about 200 on intensive care, many of those severely treated had glucocorticoids for much longer time than only these 10 days that was recommended in recovery. So I had many patients that just had been abruptly stopped on glucocorticoids. If you are abruptly stopped on glucocorticoids, you are also chronically fatigued. So something always to be ruled out, but these post-COVID symptoms, of course, are not identical with just adrenal insufficiency. They have many other aspects, and we've heard, I think it was very nicely summarized by Professor von Messling today, it is a heterogeneous group. I mean, we have to admit that this group is very heterogeneous, and if you see these patients, you realize that, and this makes it so difficult to find clinical trials that will have, well, in the end, evidence-based significant outcomes. What is interesting that many meta-analyses indeed showed that not only for COVID, for the acute infections, but also for the post-infectious syndromes, clearly if you have diabetes, metabolic disease, the risk was increased sometimes in some of these studies 4 or 5 times. And that was also related to obesity, to lipid disorders, so it seems maybe some of these viruses, probably some of these viruses need lipids for their metabolism, for their action, for their interaction with the receptors, for their mere survival. So reducing lipids could be a strategy. And this is something we are quite interested in looking into. And of course, metformin has been, and that has been published in a number of journals recently in the Lancet Infectious Diseases. If patients were or have been on metformin, that was a reduction of the incidence of long COVID by 40%. Why, what Provin would be this Wundermittel gegen Long COVID? The mechanisms are unclear, but it's a medication, of course, that has many aspects in addition to lowering glucose load, dysglycemia. It also has effects that relate to oxidative stress and anti-inflammation. So we have the largest center in my clinic for lipid apheresis, probably worldwide. We treat 200 patients on lipid apheresis every week, 10,000 apheresis treatments per year. Those are patients 30 years, sometimes 20 years, 15 years on chronic lipid apheresis treatments every week, just because they have familial hypercholesterolemia. They have forms of not only homozygous, but very high lipoprotein little a levels. They would be dead, or there's patients that are 30, 35, sometimes 45, had their first stroke, had a heart attack, and they would probably have been not able to survive without being on these machines for a long time. And so it came clearly that, and I'm just finishing, that the question came up when we were overwhelmed by patients that had long COVID, if this apheresis has some advantage. We see that lipids are dramatically reduced. We also see that's, of course, the standard, that neurotransmitters could be reduced, inflammatory cytokines, and rheology could be improved. You know that long COVID and therapeutic apheresis, there have been a couple of studies, mostly cohort studies, smaller studies, with some prominent patients, as you know. And then Frau Professor Scheibenbogen, others have shown some improvement in smaller studies, like what we have seen. Recently, there's one controlled trial that has no effect. We can discuss, I was reviewing that, why we believe that this doesn't show much. But it shows, again, a heterogeneous group. How would you get a significant result from that? We are waiting for 3 further randomized trials on these apheresis studies. I think we do need better criteria, selection of the patients, updated biomarkers, optimal apheresis filters, targeting what we've heard also this morning, thromboinflammation, targeting, in fact, also and maybe some of those factors related to netosis that we see play a major role, to microclots. And just to finish up, there are filters now in this apheresis that have been developed that can remove the thromboinflammatory factors, netosis. This is a patient I have been discussing also with Werner Seeger that had probably long COVID and some form of pulmonary fibrosis with a very bad oxygen consumption rate, and with treatment of apheresis dramatically improving. We don't know the mechanisms. It could be reduced of these microblots significantly, and we have one of those patients who was in fact with long COVID, neuroinflammation, almost paralyzed, and after some treatments could then at least get some of his life back and walk around in my office. So we need more research, definitely. We need a panel. As Dr. Stark said, we're probably a panel of markers to decide who will benefit from these treatments. And the take-home message is understanding the evolutionary context and looking in the follow-up, in a long-term follow-up of metabolic and endocrine factors, and also always rule out, if it's not an adrenal insufficiency, and protocols for randomized clinical trials. Thank you to the funding bodies, and I think we have this brain fog in science, but if we walk up a little bit higher in the mountains, we can get a clearer picture, but we need to work together. Thank you.
Thank you, Professor Bornstein, for these important insights, for showing us so many results and evidence. We were asked to keep an eye on the time, so I can only allow one question to your presentation. I would like to ask you, are there any questions in the audience? Or is there any question in the chat? Okay, we noticed one comment in the chat and that we have audio problems, so maybe you could check on this. No problems anymore, okay. And one question?
Yeah, wonderful talk. I was wondering if you had a diabetes person in front of you, so what would you recommend the most? It's more lifestyle changes or metformin or statins or whatever. So just are they aware of that also by changing maybe their microbiome, by changing diet, doing more sports, they could maybe improve on their prognosis?
Are you talking about, in general, patients that have already long COVID, that are...
No, the ones that are diabetic people.
Yeah. No, absolutely. Throughout the pandemic and through all infections, definitely it seems that metformin, lowering lipids, and definitely not getting off antihypertensive drugs, and physical activity is positive for prevention of that.
Again, thank you very much. Our final speaker is Klaus Knoch from Dresden, addressing the role of SARS-CoV-2 NSP1 from a molecular perspective on metabolic pathology, I guess.
Hello everyone, and thank you to the organizer that we can present some data about SARS-CoV and type 1 diabetes. We heard a lot from Professor Bornstein about infection, post-COVID syndrome and diabetes in common. Here we want to focus a little bit more on type 1, and I want you present some data from the lab. So it will not be some patients' data. You will see more, or let's dive into the cell and look what the SARS-CoV is doing into the cell. Actually, I can waste this slide because you saw it already from Professor Bornstein. Relatively early after the start of the pandemic, it was clear that the SARS-CoV can also infect beta cells, although we have to say the beta cell is not really a cell which expresses ACE2 very high. It's low, but still there are a virus in the beta cell, and also there is a relationship between autoantibodies against SARS-CoV and the development of autoimmune antibodies against the pancreatic beta cell. Interestingly, I want to introduce also this study from our colleagues in Munich, where you clearly can see they looked for more over 1,000 babies, and they clearly show that the risk to develop autoantibodies against the beta cell is 5-fold more in the babies, babies up to 1.5 years. So, and now the question is, how can the SARS-CoV, the virus, actually change the beta cell that it leads then to a mistake in the immune response? That's why, you know, this is a scheme of the virus. The SARS-CoV virus is actually a very, very complex virus with a lot of proteins. And at first we checked the different proteins, how they affect insulin biosynthesis and beta cell function. And as you can see here, only this NSP1, this non-structural protein 1, actually reduces insulin, and also all other granule proteins. Are here a pointer? Yes. Here?
This one. There.
Okay. Yeah. Okay. We see here the other tested non-structural proteins didn't show any effect. And you see we lose insulin dramatically. Also the granule proteins which form the insulin-containing granule. And you see also here the beta cell is not any longer able to answer to glucose stimulation, and the secretion is also reduced. And I make it short. Then we ask on which stage of the biosynthesis of the secretory granule proteins is this inhibition. And as you can see here in the control cells, you see actually the biosynthesis of the insulin starts in the ER, and after labeling, after half an hour, you have the insulin trafficking to the Golgi, and after 90 minutes, you see the insulin in the granules. I hope you see these dots. This you see also with the NSP1 as our control, but if you overexpress this NSP1, you don't see any longer any labeling of insulin, meaning the block of the insulin biosynthesis must be before the endoplasmatic reticulum, must be directly at the ribosomes. And this is clear if you look deeper into the function of this NSP1. The main function of this NSP1 is the blocking of the ribosomes. No host mRNA can go any longer to the translation pathway. And this actually is the reason why also insulin mRNA translation is blocked and the other ones. But surprisingly, what we found, the biosynthesis of the HLA or the MHC-class I molecules, which present the peptides on the surface, is not blocked. As you can see, you stimulate with interferon gamma the biosynthesis of this MHC-class I molecules, the beta-2 microglobulin and the H2. This is a HLA molecule of the mouse. And you see NSP1 is not able to block it. And this is really surprisingly because NSP1 is known to block the total translation of a host cell. You see also the distribution of the MHC-class I molecule is not changed. You see nicely a surface staining. So now we have to go a little bit deeper into the theory. Usually if translation is blocked, usually also the viral translation should be blocked. But this is not the case because the virus has on the mRNA, of its own mRNA, this little stem loop, and this stem loop is recognized by the NST1, then it opens the ribosome and it can be translated. And this is actually, to make the story short, also the case for our MHC-class I molecules. We did a reporter gene assay. If you want to know more, we can discuss this in during the coffee break. You see the MST1 overexpression is not able to reduce the translation of our reporter gene, but if you look to the insulin and also to the ICF12, this is a islet autoantigen 2, is strongly reduced. Meaning our MHC class I molecules should also form these stem loops. And if you block this stem loop formation with antisense oligos, you can also reduce again the translation. Meaning, parallel, we also see got a very strange effect. The NST1, usually if you go through the pathway, secretion pathway from the ER to the Golgi, to the granules, you have a reduction of pH. And this is important also for the MHC class I loading. You know the MHC class I molecules are loaded in the ER, then the pH is reduced. In the Golgi, you see it here in blue, and then the peptides can be changed, replaced, and only the strong binder stay on the MHC class I molecules and can go to the surface and then be presented. And this is not any longer the case if we have this NSP1 overexpression. Then we checked the immunopeptidome of our cells, and as you can see here in the result in blue, this is an isolated immunopeptidome of our control cells. Nicely, we have the peptides against insulin, ICF12 against our granular markers, and these are actually lost in the group of the NSP1. Meaning, we lose actually the identity of our cell. If the immune system now is coming to the infected cell, it will not any longer detect these peptides. And on the other hand, you see here this chromogranin A, this protein, we found also here, but here we find other peptides. Meaning it's not only that we lose peptides in the infected cells, we have also new or other peptides on the surface. And this, we think, is actually the way how the immune system can make mistake, because it's not any longer recognizing the beta cell as a beta cell. Here you see again the MHC-class I in the scheme with this hairpin, this stem loop. It's translated, goes to the ER, to the Golgi, to the surface, is loaded with peptides. But these peptides are different and actually are less peptides. And no, not any longer any peptide for insulin, ICF12, and our secretory granule markers. And with this, I want to thank you, our group, and Maria and Martin and Matthias in Munich for the help. Thank you.
Thank you very much for this informative presentation, showing us these interesting results. Are there any questions from the audience? Yeah.
Hi. Wonderful talk. So I guess I had a couple of questions. You saw this really interesting change. You saw this interesting change in the capacity for insulin to be, I guess, made, and MHC, however, 1 is still being manufactured. Do you also see a change in things like PD1, PDL1, so that like a CD8 T cell might have an increased likelihood to target these beta cells?
It's hard to understand you.
Yeah, so you see the change in a decrease in insulin 1, or in insulin being made. And MHC1, however, can still be generated. Do you see changes in PD1 or PDL1 that might allow CD8 T cells to be more likely to target these beta cells?
We haven't checked this yet.
Hi. Is there any precedence for this hijacking of the Golgi apparatus? So has this been shown to occur in other infectious diseases, or maybe a precursor of COVID-19 such as MERS?
Actually, I'm coming from, as a type 1 researcher, from the enteroviruses. Enteroviruses play are much more important in type 1 diabetes and the triggering of the autoimmunity. And also there, we see a change in the pH. It's different to the SARS-CoV, but yeah, we see it. Interestingly, you don't see so much Golgi stress if you measure. The Golgi looks somehow normal, I have to say.
And do you know if this...
Also, the pH is different.
Yeah.
And what we now have to check, or what a student is checking, if the change in the pH changes the glycosylation of the receptor for the SARS-CoV, because this, in theory, it could be a mechanism how the SARS-CoV sees other virus are swimming around. I'm already in the cell, because it's known from the glycosylation of ACE2 that wrong glycosylated ACE2 has reduced binding to the virus. So this could be or I don't know, is this answering your question?
Yeah. Thank you so much.
Yeah. Good.
I encourage more questions in the coffee break. I would like to close this session. We would like to thank all speakers for their excellent contributions, and thanks to you, to the audience, for your engaging questions. We will have this coffee break now and then continue at 11:15. Please enjoy the rest of the symposium at this very beautiful place.